Welcome back. For this lecture, we're going to continue our series on advanced airway management, and we're specifically going to talk about advanced airway management theory in this lecture. While you'll learn the specific steps to each skill in the laboratory setting, we want to talk about some of the indications and considerations when we look at moving toward advanced airway management skills, such as oral tracheal intubation. One of the most common mistakes in advanced airway management is honestly moving to advanced airway management too quickly. We as advanced providers often get hung up in the idea of because we can do something, it also means that we should. And this is often true for trying to engage in advanced airway techniques such as intubations. The most critical steps for a patient who is experiencing airway compromise is to be the least invasive as possible while still achieving the ultimate goal of ensuring airway patency. And since one of the most common airway obstructions is indeed the tongue, most of these patients can effectively be managed with basic airway maneuvers. So anytime that we approach a patient with an airway compromise, we have to remember to start really with the basics first. The most common airway occlusion being the tongue. Simple measures like a head tilt chin lift or a jaw thrust with the placement of a simple airway adjunct like an OPA or an MPA can really be a determining factor and may all that the patient needs. We may be able to correct the issue with those simple interventions and continue to ventilate the patient with a bag valve mask or provide supplemental oxygen until the patient can get to definitive care. You may revisit advanced airway procedures later in your patient care process due to the ability to need for more definitive airway protection. It's not completely unreasonable that while you can maintain the airway early on with simple airway maneuvers, as you progress through patient care and the patient becomes more stable and you need to establish a more definitive airway methods to intubate the patient, then that's perfectly reasonable. But remember, particularly as we're going through the initial and primary assessment phases, the most simple solution is often the best solution for that patient, especially considering the risks associated with advanced airway maneuvers and techniques. So let's talk about why we might need advanced airway management. The primary reasons for indications for advanced airway management is that the failure that the patient or the provider has an inability to maintain a patent airway and the failure to adequately oxygenate and ventilate the patient. This involves the insertion of advanced airway devices such as an endotracheal tube. Remember, we do have lesser tools available or less invasive tools as well, such as BIAD devices that we could use to solve ventilatory problems if the needs were met by that device. Ultimately, when it comes down to choosing advanced airway management, the choice should not be dictated by the provider, especially early on in the patient care sequence. The patient's presentations and the inability of response to a specific lower level treatment, such as a head tilt chin lift or simple airway adjunct, ultimately drives the need for advanced airway management. The decision on whether or not to intubate a patient is ultimately not up to the provider. Rather, it's dictated by patient presentation. One of the things to consider early on in moving toward advanced airway management is predicting the difficulty of the intubation. Anatomical findings like congenital abnormalities or recent surgery, trauma, infection, neoplastic diseases can all determine or help you predict how difficult the intubation may be or the procedure for placing an advanced airway in this patient. One of the assessment techniques that we use is the Lemon score. The Lemon score allows us to evaluate a patient based on their physiologic presentation and their physical characteristics, how difficulty their intubation may be. So first, you're going to look externally, right? Things that will make an intubation significantly more difficult. Things like morbid obesity, dental conditions, or short, thick necks. We use the 3-3-2 method to evaluate this. So we're looking for a score of 3, a mouth width of more than or at least 3 fingers, a mandible length of at least 3 fingers is best, and a distance from the hyoid bone to the thyroid notch of at least 2 fingers is best. Patients who can't open their mouth fully, or patients who have short necks or short chins or mandibles, can be extra complicated or extra difficult when it comes time to intubate. We also can evaluate their oral openings based on what's called a Mallampati score. And with the Mallampati, we're looking at class 1 through class 4. And this is based on the amount of the posterior pharynx that's visible when looking directly into a patient's mouth. You can see in a class 1, the entire posterior pharynx is fully exposed, while in a class 4, no posterior pharyngeal structures can be seen at all. The tongue and the hard palate occlude everything into the oropharynx and pharyngeal space. Here are actual pictures taken that can kind of show some of the differences there. You note in a lower level Lemon score, it's much easier to see the glottic opening. And this is through video laryngoscopy. So you're not looking in the mouth, you're looking directly at the glottic opening here. But you can see how additional tissues can further complicate the view for these patients. In endotracheal intubation, the ET tube passes through the glottic opening, is sealed off with a cuff, and inflated against the tracheal wall. We generally have two types of intubation that we deal with, really one primarily now, which is orotracheal intubation, or where the tube is passed directly through the mouth, and a less common skill than nasotracheal intubation, where the ET tube is passed through the nares and then ultimately into the airway. And while we have considerations for each of these and considerations of difficulty on how potentially difficult an intubation may be for a patient, understand that if a patient has the inability to oxygenate and ventilate, and you as the provider with other means have an inability to oxygenate or ventilate this patient, the next step is to indeed attempt an intubation. You're going to have to move this direction. So while assessing is important to understanding how difficult that airway may be, it doesn't preclude your necessity as a provider to be able to secure this patient's airway. One other note on that, not every EMS service or every state allows the use of orotracheal intubation for paramedic or AEMT providers. It's important that you conform to your local state laws and regulations, as well as your local services, guidelines, protocols, and procedures to ensure that you're operating within your scope given to you by your service, your state, and your medical control physician. Some of the advantage with endotracheal intubation. This is the only definitive way to secure an airway. If you will recall some of our basic airway discussions, we talked about devices like OPAs and NPAs while they facilitated moving the tongue away from the posterior pharynx or oropharynx area, and while tools like BIADs help deliver ventilatory support, none of those fully protected the airway to ensure that the patient had an adequate patent airway directly into the trachea. Endotracheal intubation is the only procedure up to this point that serves that tool. It protects against aspiration, it secures the airway, and in rare cases can be used as an additional route for delivering medication, although we don't practice this in EMS much anymore after the adoption of intraosseous as a widely used route of medication. Some of the disadvantages, there are some special equipment that's required, and some of the physiologic functions are bypassed that help protect the patient. Some of the complications that can be associated with endotracheal intubation, things like bleeding, hypoxia. This is a very large risk, particularly if the endotracheal tube is passed into the esophagus instead of the trachea, in which case you're now ventilating the stomach, which is not an adequate route of ventilation. You ultimately can suffocate the patient by doing this. Laryngeal swelling, laryngospasms, you can damage the vocal cords. You can damage the mucosal membranes, and you can create significant barotrauma if you overinflate the chest. The basic structures for the endotracheal tube are listed here on the screen. You'll note that the tube is comprised of a solid plastic tube, and at the end of the tube, there is an inflatable cuff. At the distal end of the cuff, you'll note a small hole in the side of the tube that is known as the Murphy's eye. And the tube extends upward to a plastic cap with a 15 millimeter adapter. This 15 millimeter adapter will connect to your bag valve mask to be able to ventilate the patient appropriately. Off to the side of the tube, there is a tube that runs to the pilot balloon that can be inflated and has an inspection valve or a small balloon there that you can use to determine the tension in your cuff. and it's typically inflated with a 10 millimeter syringe. Size ranges from 2.5 to 9 millimeters of inside diameter and 12 to 32 centimeters in length. And we'll talk about the choosing of sizes here shortly. You can see here several ET tubes of varying sizes. The diameter is noted on the side of the tube. You can see this top tube is a 7.0 ET tube, and the bottom tube has an inside diameter of 9 millimeters. The stylet is a semi-rigid wire that's inserted to the end of the ET tube to give you mobility and flexibility in manipulating the angle of approach for the endotracheal tube during intubation. It helps maintain the shape, and a couple of things to note about the endotracheal tube stylet. It should never be passed further than that eye of Murphy, which, if you'll remember, was the hole in the side of the tube just past the distal balloon. The end should be bent to form a gentle curve of the endotracheal tube as you're performing the intubation. And it should be lubricated, the tube should be lubricated, and the stylet should be lubricated to ensure that it has easy removal. With modern materials, some endotracheal tubes come pre-filled with a stylet. In that case, there's no additional need. You can shape the tube to the patient and then remove the stylet once you've successfully intubated. For pediatric patients, you're generally going to use sizes 2.5 to 4.5 millimeter. The funnel-shaped cricoid rings form an anatomic seal with the endotracheal tube, and there's no need for a distal cuff in most cases. Depending on the service that you work for, your pediatric tubes can either be cuffed or uncuffed. You want to use anatomic clues to help determine the size of endotracheal tube that you're going to use. For most male patients, tube sizes between 7.5 and 8.5 millimeters are appropriate. For most female patients, 6.5 to 7.5 are appropriate. A good general rule of thumb is to have a 7 or a 7.5 available for most of your patients. But realistically, if the airway is larger when you go to intubate the patient, you should opt for a larger diameter tube. This is because the smaller tubes provide additional resistance and have less ability to ventilate the patient effectively. You should always have at least 3 sizes of tubes unpackaged and ready to go for intubation as part of your preparation. The tube size that you think will work, and a size above and a size below. Preparation is really key in being successful here and making sure you have all of your equipment set up and ready prior to your intubation. You also can use the diameter of a patient's pinky to help determine what tube size might be appropriate. There is some correlation there between that, the size of their pinky and the size of their airway. As far as laryngoscopes and blades, there are 2 types of laryngoscopes that we'll deal with in EMS. You'll have laryngoscope handles for direct laryngoscopy, which is what you see here on the screen, and then you'll have video laryngoscopy, which we'll talk about later. For direct laryngoscopy, the handle is going to consist of a steel cylindrical handle. It's usually in 2 sizes, what's commonly referred to as an adult size and a pediatric size. There's nothing that precludes you from using a pediatric-sized handle on an adult-sized blade, and for some providers, the pediatric handle provides a better grip and is more comfortable, particularly if you have smaller hands. When we use the direct laryngoscopy technique, we're using the handle attached with the blade to directly visualize the vocal cords prior to passing the tube. We deal with 2 types of blades for direct laryngoscopy. The first is the straight blade, or the Miller and Wisconsin blade. And for this blade, the tip extends beneath the epiglottis and lifts up. This blade is particularly useful with infants and small children, but it's more likely to damage teeth in adults, and you'll have an opportunity to practice with each of these in the lab. The curved blade, or the Macintosh blade, conforms to the tongue and the pharynx. The tip is placed in the vallecula, which is the space where the epiglottis meets the pharynx, and it indirectly lifts the epiglottis to expose the vocal cords. Blade sizes can range from 0 to 4, with 0 and 1 being most appropriate for infants and children, and 3 and 4 are generally considered adult size. For pediatric patients, you're going to base it on age and height, and for adult patients, you're going to base it on the provider's experience and the size of the patient. And we're going to go over specific techniques for using each of these in the laboratory setting, but I want to make you aware of them before we get that far. The McGill forceps help remove airway obstruction. This should be part of your preparation set as you're preparing for intubation. The McGill forceps are shaped such that with direct laryngoscopy, you can use the McGill forceps to remove physical items that may be providing an airway obstruction. You also should have your suction prepared and ready to remove any liquid or aqueous material that may be blocking your view. With direct oral tracheal intubation or oral tracheal intubation with direct laryngoscopy, the ET tube is inserted directly into the trachea while you're visualizing the glottic opening with the laryngoscope. Some indications or need for the use of direct laryngoscopy are airway control needed due to coma, respiratory, or cardiac arrest, but it only should be utilized if other means are not more effective and time sensitive. So for example, a patient that you're unable to oxygenate or unable to ventilate by other means with the conditions of respiratory or cardiac arrest. We shouldn't negate other treatment in order to intubate a patient if they can be adequately ventilated and oxygenated by less invasive means until we've completed the primary survey and moved into the secondary phase of patient care. Ventilatory support before an impending respiratory failure, prolonged ventilatory support, and again, that's an item where we may come back to intubation after we finish that primary survey. They also should have things like an absence of a gag reflex. If they have a gag reflex intact, you may have to use medications to facilitate intubation. Impending airway compromise or medication administration. I would argue that with today's EMS, medication administration should not be an indication alone for intubating a patient. We have other tools at our disposal, including administration of intramuscular, subcutaneous, or intraosseous medications. Some of the complications we'll need to be aware of: an intact gag reflex, an inability for the person to open their mouth because of trauma, dislocation of the jaw, or pathologic condition, your inability to see the glottic opening, copious secretions, vomitus, or blood in the airway. And while all of these are relative contraindications, I think there's an important distinction to make here. We mentioned it early on in the lecture. If the patient presentation dictates the need for airway management, then these become relative contraindications. Obviously, you have to be able to see the airway to manage the airway, but you will need to use other tools at your disposal to help facilitate this process. Things like suctioning, things like use of McGill forceps. Okay, you're going to have to be able to manage this patient's airway if their presentation dictates it. So while there are significant implications, you need to ensure that you're comfortable and competent with this skill set, as this will be a fundamental part of your patient care and patient management. These are high acuity, low frequency skills that we perform as paramedics, and you should practice them often, not only in the laboratory setting while you're in school, but practice them frequently once you're out of school and in the field. It's not uncommon for paramedics to go 6 months or a year without having to intubate a patient, and you don't want the first time that you've intubated a mannequin or practiced this skill to be in a critical patient that needs your intervention for survival.